Okay, hello everyone. Welcome to the part 2 of the arrhythmia class, right? So here we'll just go through very basic ones. So as mentioned, some parts have to declare they are very confusing in a way because a lot of times you don't really know exactly how the drug works. So most of the time you get very complicated answer that maybe goes through here, 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 and here. So this is how the whole arrhythmia class is about. So there's a few principles. So the first thing is that we try to know how can it happen, right? So if there's any precipitating factors that we can eliminate, obviously we try to eliminate that. And we need to establish the goals of treatments because we need to understand the basic part that some arrhythmia should not be treated because remember the drugs that we can have is not the best. So if it's not life-threatening, for example, and it doesn't cause any symptoms and we can just literally ignore it. So some symptoms are due to arrhythmia, so then you have to choose. And remember, there's a lot of non-pharmacological approaches as well, so don't forget that part, right? So we'll go through some part of it later on, right? So we need to minimize the risk because remember, the drugs are not the best. So some anti-arrhythmic drugs can cause another type of arrhythmia. And sometimes you need to monitor the plasma concentrations for some, and there's also some patient-specific contraindications. So for this slide, we'll actually look through the different classes of different families in actual work of anti-arrhythmic drugs. So, but this is actually a very rough categorization because it's mainly based on the effect on the electrical behavior, the effects on the ECG or the plateau pattern that we talked about just in the previous class later on. So and bear in mind, a lot of drugs actually, they are most of the time they are quite old, so it doesn't have a very clear mechanism of action for some of it. So it's again a very agak-agak, a very rough estimation. And sometimes it's I think it's a little bit of guessing, to be frank, because it says that it can does everything. Okay, so we'll go through some of it. So the first class is the newer one, which is a membrane stabilizing drug. So there's a lot of examples within it. So, but the two main ones that is being used is flecainide and propafenone, right? So this for this class of drug it mainly acts on the sodium channels, right? The second class of drugs is something more familiar. It's like, oh, thank goodness, something that is more, it's clearer, which is called beta blockers. Third class of drug, so this is another newer one. So this one is something that can prolong action potential. So this is also some of it which could, meaning you prolong the QT interval. So again, remember some of the drugs can also cause arrhythmia as well. So some of it are here. So in class 3, the more popular option is amiodarone. And we got class 4, again, thank goodness, something more familiar and straightforward called CCB. So obviously you want something to act in the heart because you're looking at arrhythmia which occurs in the heart. So the role of CCB would mainly be on verapamil and a little bit on diltiazem if you want to use. Right, so let's go through the first one, which is actually on the sodium channels. So there's a concept that you need to understand. How does the drug actually achieve selectivity? Because remember, sodium channels is something that occurs all over around. There's loads of it around the different cardiac myocytes, isn't it? So how does it selectively block? So you can see that the overall transition phases of the sodium channels, you've got the resting phase, which then can be activated. So at the resting phase is the one that is can be responsive to the signal. Then it can be activated into the open ones. Then it can be inactivated to be the closed ones. But at the inactivated state, it's closed, but it's not really ready yet to receive another signal. Important, it's because yes, the drugs, all of it in the class 1 actually has higher affinity towards the open, which is over here, and also the inactivated state, right? So because these are the two states, because remember, if the cells are in overactive form, so obviously a lot of it will be activated, and also after activated, so this is the next phase, which is a partially resting phase. So therefore the drugs will actually selectively act on these two phases. So therefore, which is most likely to be the arrhythmia source, which is also the ischemic tissues that we're talking about this. Okay, so in class 1, there's actually a few subtypes as well. So there's a few mechanism of action. So we look at one by one, right? So the first one is also it can act as a fast sodium channel blocker. So you can see so this is mainly on the SA node, as you can look at the diagram of the membrane potential. So what happens is that this is the normal threshold, this is the increase. So you can actually increase the threshold so that it becomes a little bit more difficult to be activated, right, and has a decreased slope of depolarization. So for some of it, there's addition of the drugs can actually cause a little bit of hyperpolarization as well. So details you can just read through. So as a fast sodium channel blocker, so therefore if you blocked it, so it leaves less channels to be open in response to another wave of depolarization, right? So as a result, you get lesser SA node automaticity, so you get less rate of depolarization and lesser heart rate. Okay, so this particular slide actually shows one of the reasons why the medications in class 1 could possibly cause arrhythmia as well. So it actually links to the re-entry process. Remember, as explained in the first slide, in the slide previous one, sorry, I can't jump back, if not you just delete whatever I recorded just now. So it actually slows down the action potential. So you can imagine that if it slows down enough, that the re-entry occurs, the signal just managed to turn upwards, and the cells over here could actually respond to another signal already. So therefore, you can actually trigger an arrhythmia if it really happens. So it depends on how much it's being slowed down. So hopefully it's slowed down in lesser in a way, so that it's not too much that re-entry could occur, right, in short. So so you can see the main effect of class 1, it actually has an effect on the SA node, but actually when you look at the next slide, it actually shows that in class 1 it's actually subdivided again to class 1A, 1B, and 1C, which has different effects on the ventricular action potential, right? So look at here the class 1A, 1B, and 1C. So you can see this the dotted line one is the effects of the drug per se, right? So 1A is the moderate block, right? So it can cause a shift this way. So 1B is the mild block, and 1C is the marked block. So it's the most block in 1C. But the most block in 1C, as you can see, is good in a way that it does not cause any changes in the repolarization. So meaning the response time is much slower, right? So actually a lot of drugs in class 1, which is more popular being used, is actually under 1C. So 1A, you can see there's a lot of other weird name drugs in a way, like 1B as well. There's lidocaine, phenytoin. You might be thinking, why on earth is this anesthetic over here? And phenytoin, which is mainly used for epileptic control. Sorry, my boy. Okay, so yes, flecainide over here as well. So as mentioned, the more popularly used one in clinic is 1C. So there's some general MOA, as you can see over here. So I won't just repeat everything. So basically it's a moderate block, and it's also block the the potassium channels a little bit as well, right? So you can see there's a lot of drug examples. So all of it has its own side effects and so on and so forth. So it's mainly replaced by class 3, in this case the potassium channel block, which we're going to go through later. And remember, there's also other non-pharmacological treatments of arrhythmia as well. You've got procainamide. So these are the text for it. So again, there's also some not very pleasant long-term side effects as mentioned here, right? So and the last one over here mentioned is disopyramide, right? So again, there's quite a lot of contraindications, and there's some side effects as well, right? So you can see that the drugs are not great. So you can see that when you look at the indications of it, is just remain for more life-threatening conditions only. Okay, so we move on to 1B, which is only a mild block, sorry. So it's a little bit of blockage, but it's enough in a way to cause the certain effect that you want. So it's quickly recovered. So it's good to just mainly use for the MI based, right? But it doesn't really show much decrease in mortality, so therefore it's not the best to use. So theoretically, this is what happens. So yeah. So basically, you have an increase in the H plus concentration. Therefore, you activate the more potassium to get out of it, so you can get more depolarization of the slope. So there's increase of likelihood of action potential. This is happened during MI. So therefore, when you use the class of 1B, it actually slows down the speed. So therefore, it's very targeted towards rapidly driven tissues because it's just very mild blockage. So the others, if it's being blocked, the normal ones is not a great effect on it, but it's just nice enough to block those which are disease cells. Right, so you can see there are some examples. Lidocaine is the prototype. So again, you can use the emergency conditions. So because remember, it's also a CNS drug, so because it's an anesthetic, so there's a lot of CNS side effects of dizziness, confusion, so on and so forth. Mesillatine is also another one, so analog of lidocaine. So you can see that again, there's also quite a bit of side effects. Yes, you can use in adjunct therapy with amiodarone. Amiodarone is the class 3 one, which is something you definitely need to remember. We'll go through later. Right, so there's also phenytoin, so anti-epileptic, so it can be used for young children. Right, so again, it's mainly to be used when it's not the first line treatment, as you can see. Right, when beta blockers alone fail, then you might try to use phenytoin instead. So we've got 1C. So remember, this is the more commonly used clinically one. So what happens is the most potent one. So because it's safe, because there's no effect on the overall duration of the action potential, right? So therefore, it reduces the upstroke, so it slows down, so it suppresses any premature contraction, so basically just slows down the whole thing. So therefore, it causes a prevention of the AF and also tachycardia in a way. Right, so there's marked depression on the cardiac function because the effect is the strongest. So flecainide is a prototype. So again, it's something a bit tricky because again, we don't really know exactly what is the main part that contributes. So there's some reason besides some saying that some evidence, not some saying that besides the inhibition of the sodium channels, there's also some inhibition on the ROS effect, so therefore causing an overall beneficial effect in the arrhythmia condition. So when you look at the guideline, there's also something to mention that you actually do not offer class 1C drugs such as flecainide and propafenone to actually people with known ischemic heart diseases, because again there's higher risk of the re-entry as mentioned. So therefore it's a bit tricky because you bear in mind one of the very main cause of arrhythmia that you see is actually due to ischemic heart disease, i.e. MI. So you can see the use is pretty limited in a way.